Hello, friends, and welcome to another episode of the Concussion Nerds podcast. And today you're going to hear a second voice on the show. Dr. Rachel Parker, we're going to introduce you to her more in a second, is a chiropractor who is super passionate about concussions. She is part of my team at Symphony Brain Performance. She has gone through the Concussion Nerds program. She's helping me lead the weekend with the Concussion Nerds when that comes. She is an amazing, amazing human with so much knowledge to share. And so I'm really excited because I asked her if she would be interested in co-hosting this with me periodically, and she said yes. So you're probably going to hear Rachel's voice on here at least once a month. So Rach, welcome.
Thank you so much. I'm excited to be here.
Let's share a little bit about who you are. And this audience knows who I am, so they don't need to know more about me. But who are you? What does your love of concussion come from? Give us a little snippet.
Okay, so a little quick synopsis, I guess. I grew up playing a whole bunch of sports and saw the good and the bad sides of concussion rehab and the approach people took to concussion care and how serious or not so serious it was taken. And so that led me to University of Calgary, where I first learned about functional neurology and honestly felt back because I was not one of those kids that grew up going to the chiropractor, but from there went to Portland, was a part of the functional neurology clubs, learned about CARIC, learned about this kind of different approach to treatment and assessment of concussion, and eventually that led me to Nanawa.
Yes. I love it. Rachel came and shadowed the clinic. So she did a bunch of my master classes. It was a common name that I would see register. And then you always came live.
Yes.
And then Rachel actually came and shadowed at the clinic. Were you guys on vacation? Is that? Yeah. So they hear us passing through. So they reached out. So that was the first time we met in person. And then she joined Nerds. And then we started talking about her coming to the clinic. And now she's been part of the Symphony Clinic since October. And she's not going anywhere. So just in case you wondered, this is where you're going to retire. Okay.
We'll be here forever.
Okay. Well, I am so stoked for this audience to get to know you and to have someone to like banter on some of this stuff with, because sometimes it's me tangenting like a banshee. We all know that. I do it in the clinic too. So, but today we're actually going to talk a little bit more about two systems that everybody geeks out on. It's like two systems that when people are like, I want to know more about, it's always these two. So we're going to look a little bit more at the vestibular system and the oculomotor system. And when you look at the research and when you look at the phenotypes, right? So we talk about the 7 different phenotypes of concussion and how both Rach and I feel like it's important that we do our comprehensive multi-systems assessment to make sure we are screening and deep dive assessing for persistence for these phenotypes, because we know that symptoms overlap between them. And if you're not doing that full assessment, you could be missing something. And that's going to slow care or make things harder for our clients. So when you combine the vestibular and the ocular systems together, though, when you look at research, it makes up more than 1/3 of the individuals who are struggling with concussion. And if someone has vestibular or ocular issues, if they don't spontaneously resolve in the first 10 days, which is what the literature will talk about, they need rehab. They need rehab.
Sure do.
It is not sit there, twiddle my thumbs, and my vestibular system's going to heal itself. It's no.
We're not sitting in a dirt around. We're not doing nothing.
They need our help. And so I always love this one because in every workshop I teach, I ask the therapists or the clinicians, what is your assessment tool for the vestibular and oculomotor system? Rach, what's their answer always?
VOMS.
Oh, the VOMS. It is validated. It is standardized. It has a lot of really good things about it. Rach, what's your thoughts on the VOMS?
It's general, right?
Yeah.
At least people are looking at these eye movements. They are looking at different parts of the visual and vestibular system, but it's pretty general. You're not getting into the specifics of what aspect of that movement is not integrating properly or not working properly. We're not looking at any directionality.
Yep.
It's more of, in my opinion, is a general screen.
Yeah. So love, hate, right? Like love because it's given us a very quick, easy, no equipment needed screen You're going to keep hearing us call the VOMS a screen of these systems. We know that if a client, a patient, depending on how you talk about your person, has a change of greater than 2 points, that is indicative of a concussion. I love that. That's my love of the VOMS. My dislike, I shouldn't say I hate. Hate's a strong word. There's no hate relationship with the VOMS. Where I less like the VOMS is, one, it's purely subjective, right? That scoring, that greater than 2 points, is based on the client's perception of their symptoms, which, yes, it matters, but the flip of things is we're never going to clear an athlete for play based on symptoms alone. So in my brain, our assessment needs to not just be based on symptoms alone, right? And the VOMS, although it's, again, a fabulous screen, and yes, you're looking at things, the whole context of the scoring system of the VOMS is symptom-based. So that's my not love of the VOMS. And then the exact same reason you said, Rach, about it's general. Like, it doesn't pull into directionality. It doesn't pull into speeds. It doesn't pull into these other aspects where when we assess and treat, everything matters, you guys. Like, let's talk about, okay, vestibular oculomotor screen is VOMS, right? So for those listening and that's new, you can literally Google it and find it everywhere, along with the scoring sheet and how to perform it. Easy peasy. And there's a lot of different research on there. People are saying that if the oculomotor component produces more of the symptoms, that's actually indicative of a longer recovery process. Dizziness as a whole, longer recovery. Dizziness can come from vestibular or vision, right? So there's all these different things, but do you want to give a quick highlight maybe on for those that the VOMS might be new to, because we have people of all levels listen to the podcast. What is the VOMS looking at?
Yeah. So the VOMS, we're first looking for symptom score, right?
Yeah.
And we're doing certain tests and seeing, does that provoke a patient's symptoms or not? So we're looking at different eye movements. We're looking at saccades or jumping eye movements. We're looking at pursuits or those following type of eye movements. We're looking at vestibular ocular reflex, so that type of rest test, as well as convergence. And like we said, it's positive tests if those symptoms are increasing as we do it.
When Rach and I treat, yes, we absolutely care about our client's symptoms. Yes. Let's preface this. We care, and it is very much, you would say, a guide on how intensely we push our client. It's not the only thing that's our guide, but it's a piece that's our guide. You keep hearing us talk about, like, we go deeper. The VOMS isn't enough. It does not satisfy our brains. I just gleeped. It does not satisfy our brains enough to be able to create an individualized, specific treatment plan. And so just on the VOMS itself, we're going to give a little insider on one aspect of this. P.S. This podcast is not scripted. So poor Rach is like, this is the first one she's done with me, and she's no idea what's going to come out of my mouth. You're doing great.
Thanks. Just keep it up. Going along.
Oh my goodness. I love it. Let's talk about saccades. Okay. So what is a saccade?
Saccade is essentially a quick eye movement, right? And that's one of the most common eye movements we use every single day. And I usually give an example of just reading to my patients. So on a page of a book, there's 200-300 words. So you're having to jump 200 or 300 times just to get through that page, right? So
I've never used that example. I like that one.
Quick eye movement, jumping eye movement.
Fantastic. So in the VOMS test, again, I'm not bashing the VOMS. I just feel like I need to say this. I am not bashing the VOMS. It was created by a group of people who I greatly respect, and continuing on. So the VOMS is literally like you hold up 2 targets and you jump your eyes back and forth between these 2 targets. So first of all, that's called a voluntary saccade, which is one type of saccadic eye movement we do. One. We do many. It's one. So that's the first part. Secondly, again, in the VOMS, like, there's a note section for you to take notes, but most people literally just look at the symptom score. So when we look at a saccade, we're looking at 3 different characteristics in each direction. So you could say we're looking at 6 different things. Yeah. So we're looking at latency,
speed,
and accuracy. So latency being like how long it takes them to initiate the eye movement. So what's an example of someone that you see when you assess that has poor latency, for example?
So, for example, if they're jumping between the two targets, they might hold their gaze on the first one for a while before that initiation actually happens.
And then I always feel like where clients usually follow that up with like, it just feels hard. Or like, I have to think so much more to get my eyes to move to the direction. But that directionality matters. So the way like we link everything is we link back to anatomy. We link back to functionality too, because what we're really trying to figure out is what part of the brain is struggling. And then what else can we do potentially to stimulate that part of the brain to help it improve function without necessarily practicing the same fucking thing over and over again? I'm going to time out and share a story once. I felt really proud of myself in this moment. So I'm going to share it. So I had a client who came for an intensive. And she had a SPECT scan done. And so a SPECT scan will show you blood flow to different areas of the brain and where there's like hypoperfusion and where there's like a greatest area of deficit, right? And so she said to me, do you want to see the SPECT scan? And I was like, yes, after I do my assessment, obviously, right? So we go through our full assessment and I'm sitting there and I said, okay, here's where I think we're looking at. We're looking at like this frontal, this temporal, here's why, here's the connectivity piece. Like, this is what I want to do for a treatment plan. And I pull out her SPECT scan. And guess what? It matched. Where we were able to identify with functional testing, we identified the exact same area of deficit in her brain as the SPECT scan showed as well. It was so validating for myself because that was earlier in my journey that happened. So it was insanely validating for me and for my client who was like, I just paid
how much money to get this done?
Damn it. But no, and I think why I want to say that too is this is the tangent, is that there gets to be so much emphasis on this feeling to need a scan, right? Like we see it in clients all the time. Totally understand where it comes from. Sometimes when scans come into play, it's do we need to rule out that greater pathology? Like, is there something else going on we need to be looking at? If it's truly PCS, we don't need it. Like, put that money, which would be at least $6,000 to $10,000, depending on where you get this done, more if you go to the US, put that money towards treatment, but put it towards the right type of treatment. Okay, tangented. Okay, so back to our saccades, right? So back to our saccades. So we look at latency, which we relate to the frontal cortex of the brain, right? So when Rach says she does an assessment and your person's slower with their saccades moving to the right, what are we looking at? Right? This takes us back to being students again, honestly. And we have to relearn our neuroanatomy and our pathways. Like, I don't know about you, but in physio school, in your first semester, I think it was the first or second semester, you do a neuroanatomy course and you have to learn all the pathways. And then it's like it goes out the fucking window. Like, is Cairo school the same way?
Yeah, similar, right? We had a couple, but I think the biggest issue is you learn all this anatomy, which is super important and valuable, but you are missing that next step of, okay, cool.
Yeah.
Contralateral side, but what does that mean to me?
Yes.
And it's not until you're in this environment, or if that's what you decide to specialize in, especially treating concussion PCS, it's super important. But it helps you remember the anatomy because you can actually use it and you're putting a meaning to that anatomy.
I love that. And that's just the connection piece, the bridge of like, how does this relate to actually what I see and do every day? And I think that's where some of the feedbacks in the concussion nerds program, and like you went through nerds, so you can speak to this, is that that's what we do really well. Is we really help, because we've done courses where we learn, like Rach and I have spent between the two of us 6 figures on like continuing education courses in this realm and love them. But for some of them, it's really challenging because, again, they go really deep into this neuroanatomy for us. And then the bridge to practice is missing. And you feel like super overwhelmed. And you're like, what the fuck do I do with this information now?
Yeah, exactly. And that's like in school, right? I had started different new educational courses that dove super deep in all of this, and it was great. But at that point, we don't have the patience and that population to use the information with. It's not going to stick.
This also like boggles my brain about chiropractors. Chiropractic students are the only they are the only profession I know that does outside education while they are doing their chiropractic. Is this something that is like encouraged? Because honestly, like there's a handful of you that I know. Like, is this encouraged when you're going through your program, or like why does this happen?
That's a great question. Because who thought that taking 15 courses in chiropractic school, you also have enough time and brain energy to do more?
Right?
I need to take a pause right now. I'm not getting or gaining as much value as I should.
Right.
This information. And realistically, I'll just have to relearn it in a few years.
Right.
We took a pause, but it is common in chiropractic school.
It's like
Want to do more. Yeah, I think it honestly goes back to, especially in the States, like for Hop Neuro, for example, you can get those extra designations as soon as you're done school.
Oh, okay.
So want to start it early,
Okay. Got it.
so that they can get those designations as soon as they graduate.
I am someone who doesn't really care about the letters behind my name. I got asked if I was going to do a PhD once, and I was like, no. But then you could be Dr. Wilter. I don't care. I don't care. I care about helping people. And I feel like the people don't look at the letters behind my name because half the time we don't know what they mean.
Yeah, exactly.
But that is where I think what's super cool because we're going to go back to the VOMS. We're going to go back to some anatomy here in a second. I hope you're following our tangent line. But that is also where I think with concussion nerds, which is my clinical mentorship program, that's kind of the field. We do a really good job of helping you remember and relearn the physiology piece and how important that is in our concussion population. But then we bridge it to here's what the heck you do with it, and here's how you use it in practice. And so when we're going back to saccades and we're looking at, okay, latency, increased frontal cortex, speed, we're looking at brainstem, right? And then honestly, the amount of times I still have to go back and be like, ipsilateral brainstem or frontal brainstem? Ipsilateral brainstem for speed. This is simplifying it still, right, guys? Like if you pull out a textbook, the one our computer is currently sitting on, and you actually pathway out a saccade, clearly there's a multiple, but like generally speaking, speed is brainstem. Then accuracy,
The cerebellum.
yeah, we're looking at ipsilateral cerebellum, right? So when we're looking at someone's saccade, we're looking at those three factors: left, right, up, and down, because they're not equal, right? Like you can have this client that has a latent saccade to the left. I'm going to do some math in my brain here. And you can have like hypo or hypermetric saccades to the left, and then they're also slow to the left or slow to the right. And that's going to tell you different pathways. Also that thing of we never just use one test to determine two, right? So when we're looking at the vestibular and the visual piece, we see the clients that have seen many people, right? Like luckily, like Rachel also treats a lot of our local population, so she gets to see some acutes, which is amazing. But with our clients that we know have come from other clinics or like been on this journey for a while, what are some of the biggest things you notice? And again, we know it's like when they tell you their experience of their visual or vestibular assessment.
Yeah, so I think it goes back to what we were talking about the generality, right? So if we take the classic vestib example where, okay, you went to a therapist, they did a screen or as part of an assessment for your vestibular system, and now you're given these one-time viewing exercises, or you're given, let's look at your thumb and turn your hand left to right. They've been given this, and they've been doing things, and I think when they come to us, it's, okay, some of the tests might be similar, but it's how we look at it and how we assess it and then how we put that into treatment that's probably going to be different, right? And there's a reason that not everyone gets better with those more general vestib or oculomotor exercises. And in my opinion, it's how it's being broken down and what we're targeting and what we're focusing on that can make the big difference for someone, right?
Yeah. And I think my dream is that, you know, for those people that do recover with the general, because obviously it works fantastic for some people, right? Not 100% of people with concussion have persistent concussion, right? So we know that it works for some, but then there's obviously this handful, which again, when we look at that literature, the more general population, 55% of people are going into persistent concussion. And so why? We have our flags, but I think the piece that I hate and that I struggle with and that I know you hear me bitch about all the time is I hate that we have to fail the general
in order
to get to the specific. And I would so much rather have what we do and what I teach in nerds be that's step one.
Yeah.
And because I truly believe like we get people better who've plateaued, right? Like we watch people move the needle who've been stuck for years doing a more generalized approach. But here's what I actually think it is, because I know the therapists that do that generalized approach and they believe they're being specific. Right? And it's not that they're like the person's needs. It's not that they're not trying to tailor it. It's not specific enough. Right? And I feel like that's where we shine. So like in a general visual assessment, we know it includes the VOMS for most people. So they'll do smooth pursuit, voluntary saccade, they'll do convergence, they might do near far. I'm trying to think of like when Trevor was a physio at his other clinic, like what else did he do in his visual assessment? Those are kind of the fundamentals. And when you talk to a physio who hasn't done, or a chiro who hasn't done a more specialized course, that is the fundamental. Okay. So smooth pursuit, saccades, voluntary. Yeah. People are going to be like, what the fuck? Near far and convergence. What else do we look at?
Before you even test the eyes, we're looking at things, right? We're looking at ocular alignment. Is there a skew deviation, etc.? We're looking at accommodation. We're looking at peripheral vision, where it goes so much deeper. And I think also going back to what we've already said, like we're still looking at saccades, multiple types, and those smooth pursuits, but we really focus on how are they functioning, right? And I think generally in chiro school, and I'm sure physio school as well, it's like, okay, jump your eyes between these 2 points, or okay, follow this object. Can they do it fairly well without symptoms? Great, they're probably fine. And we know that that's not the case, right? So not only is there so much more that we're testing and looking for in the system, it's just going deeper.
Yeah. I know sometimes when I do workshops, I'll be like, okay, so we're doing a smooth pursuit to the right. Yeah. And we notice we got saccadic intrusions. We don't have catch-up saccades. And it's like, what? And again, like this is just all that is, you guys, is understanding the physiology at a deeper level. And I think when we're working with persistent concussion, that is the piece that is important. We have this obviously holistic-y approach that we look at the full person, but from the physiology piece, which let's be real, that's why people actually travel to come work with us. We physiologically understand it on a deeper level. I think things that other therapists go, oh, kind of wave it off. We look at that and go, that matters. Yeah, for sure. I know I think of Steph who came for an intensive, and I've shared Steph's reels and stuff online, and she's done vestibular therapy. She's all the things, right? And every time we tilt her head, she'd go into complete blepharospasm on her right eye. And she's like, that's been there since day one, but no one knows what to do with it or understands what it means. So they just kind of like brush it aside and focus on other things. And we got rid of that in 2 days. And she'd had it for 4.5 years. And it was that piece of, again, the treatment wasn't the eye. Yeah. But it's understanding. And you said earlier too, like that interconnectedness of how all these things work, right? I think I love when we look at the vestibular system. Like Rach and I are both vestibular junkies. Vestibular and oculomotor, and I'm going to say autonomic, like junkies. Like those are our three, where I'm putting words in her mouth, but those are definitely my 3 favorite.
I agree.
And so I think too, if you're a therapist listening to this, if this makes me angry, I apologize, but even the vestibular specialists, the otolithic system gets missed.
All the time. I don't even remember honestly learning much.
I didn't. Guaranteed I didn't. And so like I understand why it gets missed. It's no one's fault. And even definitely in physio school, our vestibular, what I remember was like BBBV. And also I think the vestibular system is one of the most confusing fucking systems in our body. Sure. Like it is the system that I have had to like reread and talk through and like so many times. It's a confusing system and involved in so many things. Yeah. Oh my gosh. The vestibular system is not just dizzy, right? No. And so, yeah, like we never got taught it in physio school. And actually, if you look at a lot of the common concussion courses out there that are good courses that are fundamentally set you up to treat straightforward concussion very well, they also don't talk about the otolith at all. I taught an acute workshop for the Chiropractic Association, And I was like, we're going to talk about otolith. And they were like, what? And we practiced it. So it's this piece of otolith. So listening to this vestibular assessment, yes, do your head thrust testing. We do that as well, right? Do your balance testing. Your DVA testing, you guys, so dynamic visual acuity, it is a general screen. It does not give you asymmetries. And I think that's the piece too, is the questions I started asking in my profession, I don't know about you, but like they all started around the vestibular system, actually. Every question I started having that no one could answer for me was, why are we doing everything bilaterally and symmetrically? Like, it didn't make sense to me. Like, why are we doing everything left and right? Like, why are we doing everything at this like certain speed? And no one could explain it. And so I love when the research tells you that there can be asymmetries in your vestibular system after concussion. But over and over and over again, the otolithic system gets missed every single time. And then because it gets missed, you can objectively and asymmetrically assess the otolithic system. But then people don't know how to treat it. So they instantly link otolith with balance. And then it's balance exercises. And it's not specific enough. Right? So I think from the vestibular system, yes, do your DVA as a screen, right? Do your head thrust test, do your balance testing, like your modified CAT-SIB or whatever you do, but please don't forget your otolith. Super quick, like your subjective visual vertical, our ocular tilt reflex. What else are we looking at? Skew. And we have some fun tricks that we teach you in Nerds to help you kind of dig deeper into the otolith too. I don't know about you, but like I almost want to say in every single client, it's not every single client, but that percentage is like,
It's high.
Yeah.
Yeah. And sometimes it's like, I think that it's probably high in persistent concussion to begin with. But then a lot of the times, how many of these patients have seen someone else, they've checked for BPPV or they've done some of those wrong work, but they've been tested for the peripheral vertigo and it's been clear. And then they've been told, well, we don't know what to do next. Right. And that's a lot of the people that we've seen. They've seen lots of other providers before and they've done a great job in terms of like what they have the knowledge to assess. And then it's where do you go from there?
Yeah. What would you say on your clients that if you have like a couple in your head that you're thinking of that you know you were doing some significant otolithic work what were some of their symptom complaints that weren't dizziness? Because the otolith, you guys, doesn't give you dizziness. So what are some of the symptom complaints that you hear from clients that you know, like once you do it, you're like, oh, that's weak otolith?
There's a lot. I think some of the common ones would be, oh, when I go up in the elevator, I get really dizzy. Or I don't feel like the room's spinning, but I feel like I'm in motion. Or I feel like, those are kind of the more common ones, I'd say.
Yeah.
But it's not the spinning. It's not the, I feel like we're going to topple over. It's the, I feel unbalanced and don't have a good sense of where I am. Or certain things like the elevator or the escalator, like these aggravate my symptoms.
Yeah. Cool. We could clearly like riff forever, but let's give the therapist listening to this, like if they're going to assess the vestibular system, what would we recommend looking at? So head thrust test, ocular tilt, throw the DVA in if you want. We use a Maddox rod to look at skew. And so Maddox rod's typically used for ocular alignment, but we use it for ocular alignment, skew, which falls into ocular alignment. But we actually have a little trick that we use to help kind of rule in or out otolith as well. And then obviously modified CAT-SIB is always a goodie just to look at your different systems and how they impact balance. The Unterberger or Fudoku step test, I honestly don't do it. Like it's not sensitive. It is a cool one that if you know there's no orthopedic or like other confounding injuries that could impact the outcomes, it is a cool one for the client. It's a wow factor one.
For sure. And sometimes when you're doing your tilts, for example, sometimes maybe the image might get a little bit blurry, but sometimes the patient can't tell. Like we might be able to see the counter roll or those things that we're looking for, but the patient can't tell. When you do Fukuda and they have a large translation, they move forward 2 feet or they turn 90, 180 degrees and then they open their eyes. That's a wow moment for the client.
Yeah.
I just moved.
Yeah. I thought I stayed in the same spot. And I think having some of those tests in our assessment is important because it validates them, right? Like we don't need that test to know, but it validates something for the client, because then as we treat, that test is going to get better and they're going to see that. So vestibularly, like those are our go-tos, I would say. Yeah. And then our ocular motor assessment is huge, guys. Like our vision assessment is a huge piece of the puzzle. And so like Rach talked about it earlier, we do ocular alignment, fixations, peripheral vision. We do processing speed. We obviously look at saccades, smooth pursuits. We look at voluntary and reactive smooth pursuits. We look at
You say convergence.
oh yeah, convergence, divergence, accommodation, suppression. I'm trying to remember my vision assessment in my head, and it's a beastie one because there's just so many things. And then once you have that information, like there's clear places you start. If your client has suppression, you can't ignore that. I mean, suppression means they're ignoring the information coming through one of their eyeballs. Like if you identify suppression in your client, you got to fucking treat it. And if you don't know how to, refer to your neurooptometrist, right? Like this piece of things. So yeah, like, and it all always like loops back to, we need to be able to go deeper. And I think that so often as therapists, we just don't actually realize that we need to take that step or how to take that step. So any other thoughts for today?
Not really. I guess one other point I'll make is going back to that VOMS and symptom scores.
Oh, yeah, right.
That's actually one of the main reasons. Well, it ties into one of the main reasons I wanted to go into functional neurology, where when I was in university playing soccer, I knew that if I told them I had no symptoms,
Oh, this is so good.
to play. And as did everyone on my team, as did a whole lot of athletes, where if I just say, I feel fine, great. 2 or 3 days later, you'll be back on the field. And I think that that also ties into why what we do is so important, where it's not just symptoms. We're being specific for multiple reasons. And at the end of the day, we're doing it for our patients so that they're going back into life and to work and the sports when they're actually ready.
I love that. On that note, you'll hear more of Rachel, you guys, like at least once a month. And if you are part of mini school, Rachel's going to be joining me for a mini school live call a month as well. So you're going to see a lot more of her. Wishing you all an amazing day. And we'll be back next week. Bye. That's today's episode. Thank you so much for tuning in. If you liked what you heard, give us a like, give us a share, give us a tag on Instagram, and please never hesitate to reach out. We love communicating and connecting with you. Until next week, my friends, have a marvelous day.